series talk. Normally, we choose a clinical topic for expert series, but today we have diverted from our normal stream and we will discuss something that will help us to develop a good practice in an ethical way and in a patient-centric way. We have two expert speakers to guide us today, and equally expert panelist. Dr. Senthil is well known to most of us through his Ophthalmic forum, and many of us might have listened to him, might have taken his expert opinion at various stages. I welcome, on behalf of KSOS Scientific Committee and KSOS, I welcome Dr. Senthil and Mr. Rajaraman, CEO of Asaram Hospitals, who will be speaking on two important topics of practice development today. We have formal introduction of our speakers by our moderator. Before that, let me welcome Dr. Samira V, who will be moderating today's session, our energetic, dynamic retinal surgeon and owner of Sampada VR Eye Hospital. I'm happy to welcome our panelist for the day, Dr. Srini Erkalan from Talasheri, our past scientific committee chairman and owner of Malhari Eye Hospital, Eye Care Hospital, and Dr. Merin Paul from Medical Director, Trinity Eye Hospital from Thrissur. I welcome you both. Let me welcome our dear President, Dr. Rajiv Sukumaran sir, who is instrumental in bringing up all these activities of KSOS. Before I hand over the session to Dr. Samira for moderation, let me request few words from Rajiv sir.
Thank you, Dr. Sujit. A very good evening to all of you. It is my pleasure as President of KSOS to welcome Dr. Senthil and Mr. Rajarajan. As you all know, as doctors, we are trained to treat patients, but running a successful practice requires planning, management, and good teamwork. This is where Dr. Senthil's expertise becomes invaluable. Through Ophthalmic, he is helping eye care professionals understand the business side of practice in a simple and practical way. His guidance can help us improve patient care and build strong practice. So today's topic is very relevant to all of us, and I'm sure we will take away many useful points from his talk. On behalf of KSOS, I warmly welcome Dr. Senthil and Mr. Rajarajan, and thank you both for joining us today. I also welcome moderator, Dr. Samira, who will guide today's session, and a special welcome to our expert panelists, Dr. Srini and Dr. Merin Paul, whose knowledge and experience will add great value to this discussion. Let's start this expert talk. Thank you very much.
Thank you, sir. Let me hand over the session to Dr. Samira. You can introduce the speaker and start the session.
Thank you, Dr. Sujit, for inviting me. We have four brilliant people who are sitting over here. No words to tell, actually. Dr. Senthil, already I have attended one of his conferences, so we know like what all works he is doing. So he actually does not need much introduction. So it's really an absolute pleasure to invite Dr. Senthil and giving an introduction to him. So he has been trained as an ophthalmologist, but he is a visionary and a strategic thinker who has spent the last 2 decades bridging the gap between the clinical excellence and the business management, what we lack in our day-to-day practice and during our hospital work. And also we never used to see such things and whenever used to hear such classes and talks during our MBBS days. So he is the founder of the Ophthalmic Practice Development, which has developed almost more than 250 doctors who can set up their own hospitals, and WellCare Health Systems, which has screened over 2 million patients for diabetic retinopathy. So he is a true ecosystem builder, founding Ophthalmot and the Ophthalmic Academy of Visual Sciences recently. And he is a former guest speaker in Yale and Duke and a recipient of the gold medal from the government of Tamil Nadu. So he joins us tonight to share his expertise. Welcome, Dr. Senthil.
Yeah. So thank you, Dr. Samira. Nice to meet all of my friends here. I think happy to know everybody. We have interacted, Dr. Srini, Dr. Sujit, Dr. Rajiv, and In fact, Dr. Samira got one of the awards in our Ophthalmic conference. So she got the Woman Entrepreneur for Specialty Services. Because our aim in Ophthalmic is to kind of celebrate all the doctors who are doing phenomenal work and bring them to the forefront. That is one of our main initiatives. And thanks to Kerala State Ophthalmic Society for inviting me. And today I wanted to have two discussions on two topics. So first thing is about the ethical marketing as per the NMC guidelines. And then second thing is a little bit about collaborative practice. And then Rajarajan will be talking about customer excellence in eye hospitals. So basically, idea is to have it more like interactive and discussion and some carry home points. That is the thing which we want to achieve at the end of the session. Is my slide visible?
Yes, doctor.
Yes, yes.
So we'll go with this ethical marketing first. I think the slide is it there or it's not?
Now it is gone.
Just give me 1 minute. I think to the other thing. Okay. So basically, nowadays with the advent of these Instagram reels and a lot of things happening, we see most of our colleagues are in a lot of competition to get these followers, like who gets the maximum followers. And what I wanted to bring is, are we actually doing these things as per the National Medical Council guidelines, or are we going away from it? So many times I think what I see is many of our colleagues, they cross the line, and most of the Instagram activity or what we are doing in social media doesn't go as per the NMC guidelines. So I thought, let me also bring these things, what we should do, because the quest for followers is basically becoming more and more. In fact, doctors are dancing, patients are dancing, and everybody is dancing to get more followers. I think you don't need to dance to get those followers. What you need is basically create awareness. And what kind of a brand erosion does it happen? Like, see, if you see an ophthalmologist dancing along with this patient on the OT, or maybe sharing their personal reels on an Instagram, think from the psychology of the patient, will you as a patient go to that particular ophthalmologist? Because I think I will not go, because when somebody is dancing and somebody is not very serious, okay, it's an entertainment value, but how do I actually trust that particular ophthalmologist for getting operated? So definitely these lines are also being crossed. So instead of creating a brand value, a lot of brand erosion also happens. So let us understand what are all the things which our doctors are not doing right, and how do we actually not cross the line of medical ethics. So in 2023, the National Medical Council also updated certain standards for digital marketing, how do doctors should market, and it provides a very rigorous framework. The guidelines are very strict. Like if the guidelines are followed, I think most of what we are doing on the social media is not acceptable by the NMC. But as of now, I think the NMC is not taking any strict cognizance of these and let it go. But I think we as doctors should be following these things and knowing what we are doing is right or wrong. Then, before we actually go on the quest for the followers. So the guidelines were introduced in August 23, and it's available for everybody to download, and the full guidelines is available online. And then in particular, how the doctor should behave on the social media is also there. So what is important is NMC doesn't say that you should not be in social media, but they have a very clear demarcation between awareness creation and solicitation. Solicitation is not allowed by the medical council, but if you want to create awareness, it is always okay. So for example, what is this awareness creation? So let's say diabetic retinopathy. If you talk about diabetic retinopathy, the diabetic patients have to get screened once every year, and ill effects of diabetic retinopathy, that is awareness creation. But if you say, okay, diabetes, this is my diabetic patient before surgery, this happened, and after surgery, or this is the testimonial of my diabetic patient, or you message me in direct message to come and get a consultation or 50% off on consultation. All these things are viewed as solicitation. So clearly, we should understand the difference between awareness and solicitation. So creating awareness is okay as per medical council, but soliciting patients, inviting them to come, whatever rules apply offline also apply online. So now you go back to Instagram and see what are all our colleagues are doing, where how much of solicitation is also happening. So that is something we have to be very clear. As long as we are very clear between awareness and solicitation, problem will not arise. So what are all
So your slides are gone now, unshared.
Hello, slides are gone. Okay,
Yeah.
okay. Give me 1 minute, sir.
No. We can see Sujit.
Is it?
Yeah, it is very visible. No problem.
Oh, okay. Sorry. Then my problem. Okay.
Are you seeing the permitted advocacy slide?
Yeah.
Yes,
Yeah,
permitted
yeah.
Okay,
and,
Yeah.
Okay.
image.
Okay.
So
Sorry.
basically, yeah. So basically, before we see what is not permitted, let us understand what are all are permitted. Like sharing health tips, for example, talking to patients about when do you do an eye checkup, or protecting your vision during Diwali, or how do you protect from dryness, what kind of things.
Oh, hello, I think we lost him. Hello?
Yes, audio is gone.
Yeah. Dr. Sente?
Yeah, he told that there is heavy rain. His power may go in between. So you'll wait for
Okay.
some time. Yeah.
Okay.
But I was not seeing his slides by.
No, Sujit,
No,
there are
slides
two
are
tabs there on top, meeting and Ophthalmic workshop screen. Tab. You minimize it. You will get two tabs there on top. You have clicked the meeting.
Okay, sir. Okay, right.
When you click the meeting, you will see only the people there.
Yes. I got it. Yeah. I was looking for the passcode actually. Yeah. So I took the other one.
This is a new feature in Zoom. You can, if you don't not interested in the presentation,
You can switch meetings.
choose
Okay.
today.
Meanwhile, Dr. Rajarajan is here. Welcome, sir. We have actually welcomed you. You had not joined at that time.
Yeah, thank you very much, sir. Sorry, I just got held up in the hospital. I just got home. Yeah.
Yeah. We'll wait for Dr. Senthil. I think he had already told that it's heavy rain there.
Sir, your comments on the marketing through
Social media,
Instagram and all.
Yeah, see, thing is, we always talk about it as a spectrum. So there's a lot of things in social media marketing. So today, there are clear guidelines as to what we should do and what we should not do. And in fact, we are all looking at creating a lot of white papers also, which will help doctors to maneuver this. See, in fact, one of the important things which you all need to know is that when hospitals do it, we don't have that challenges and issues because we have a team and we are a brand. So the rules, NMC rules are majorly for the individual doctors. So those 6 to 8 guidelines which has been told has to be done. Many people do not know that a patient and a doctor cannot be on a single frame. So many of these things are, going to have major impact. Another major thing which I have seen in various organizations is that about the fact that the kind of claims that we make, India's first, Kerala's first, or Tamil Nadu's first, or Andhra Pradesh first, vetted and validated. How do I do it is, whichever company, say for example, we've done some cardiac procedure. So say the supplier for that particular instrument or the implant is say Abbott. We get a certification from Abbott that it is the first time in India, and then we attach the claim. So when we do this like this, what happens is tomorrow from the advertising guidelines or any ethical customer portals or various other things, if there is a claim related question that arises, we always have this written email from Abbott or any other company for that matter, whose implant or whose tool technique or this thing that we have used. There is also a wide speculation on calling ourselves best hospital. It is a good tag word to have in Google advertising, keywords advertising, and stuff. But while putting it on a hoarding or putting it in the social media, you are misleading patients. So that has to be avoided. Today, social media is a huge this thing. Today, see, the most important thing is I don't know how many of you already have your Google My Business login, GMB, we call it. Google My Business, wherein it's just that like your Gmail ID, you create a business ID, you write what time to what time you're open for your clinic or your high hospital, and you will put some pictures on it, contact numbers, details, and stuff. So
Yeah,
Google My
yeah.
Business, yeah, Dr. Sendil is back.
Dr. Sendil.
So we'll continue from the customer experience point of view after some time.
Yeah.
Dr. Sendil, you're back?
Yeah.
Thanks, Rajarajan, for bailing me out. So there is a huge electricity issue because of the rain in Chennai. Yeah. Am I audible now?
Yes.
Yes,
Your
sir.
screen,
So,
your
so
screen
what
is not visible.
screen is not visible?
No.
Yeah, screen is not visible.
Okay, give me 1 minute. I will. Okay, now it should be visible.
Yes.
So what are the permitted advocacy? So what are all the things which is permitted as per the medical council? Is one thing is health tips are okay, preventive eye care advice, or if there is a public health alert, for example, something about a conjunctivitis episode, or all those things are permitted. And if you are having a particular academic achievement, winning an award, all those things are okay. And like offline, if you are starting a new practice or if you are moving your new practice, a new doctor is joining your practice, all these things are permitted along with awareness creation. So these are the permitted things. So what are not permitted? I think this is something we have to understand. As per the medical council, definitely testimonials are not allowed, even if it is with the consent of the patient. So lot of us keep sharing about patient testimonial, patient talking, recording about how the surgery went on. I think there is a huge no as per the medical council, even if the patient is consented. So testimonials are also not permitted in the website of the hospital or any media outlet of the hospital. So that is something which is not acceptable. And the before and after, particularly many times dermatologists, they put photos of patient before treatment, after treatment, or oculoplastic surgeons putting up videos or photos of before and after treatment, definitely not advisable or not allowed by the medical council. And as Rajarajan sir was telling, like showcasing impressive results or claiming that we have done, there is now one Instagram video going on which says like, have I seen 3,000 patients, 30,000 patients, 3 lakh patients, or I've operated 200 cases? All those things are on the gray zone. I think definitely not accepted by the medical council. And so the other thing is buying likes or followers, particularly paying them or boosting a post or trying to do a promotion to solicit patients, like DM me for a consultation, message me for 50% off. All those things are not advisable or not permitted. So what they say is professional growth should be organic and merit based and not using financial power. You try to bring your profile up. That is not permitted by the medical council. An absolute prohibition on posting identifiable patient material, any photo or video which reveals the patient identity. Like this, a lot of us put the patient coming and sitting in the refraction chair, or a patient talking about the service. That is also not permitted. So a patient can post, but as a doctor, you cannot post all those things. So content, good content creating, for example, what are all the things we can do? For example, creating an eye health guide, or a guide about diabetic retinopathy, or a guide about optical selection. How do you select the good optical frames? Or something about glaucoma. Those are all permitted. And never, as I said, never prescribe in DMs. Redirect, if at all somebody wants to have a consultation, redirect them for a telemedicine consultation. And most important is auditing your website, all your social media profiles, whether you are following the medical council ethics guidelines. That is also important, because many times the content are all old and we don't know whether that is as per the guidelines or not. So ethical consider, what is the golden rule? So whatever is applicable for a doctor in an offline mode is also applicable to online content. So basically whatever I've said, like no testimonials, before after photos, identity revealing, or photos of patient funders, or surgical videos, we don't know, maybe education, that's a little gray zone. All these things are not available, advisable. So these are the, I think this is something we keep seeing every day. I wanted to bring this content to the ophthalmologist, to all our doctors who are doing, and just to be a little more careful about, are we crossing the thin line of between ethical and non-ethical as per the medical council. So we can have one or two questions, and then I can go to my next presentation if there are no questions about this.
Dr. Senthil,
Yeah.
what is the line between a doctor doing the things that are unethical according to NMC, and a hospital? It's a different entity, right? A corporate body doing whatever you say is not permitted by NMC. So putting testimonials on website, having the patients talk about their experience in the hospital on their website or in their whatever social media. So NMC has, because when Vasan was advertising right and left and center, the defense was that it's not the doctor who is doing it. It's a corporate body who is doing it. They're not bound by the guidelines of NMC. So there is nothing. And even when a hospital advertises with the doctor's photo there, it's a doctor who has permitted his photo to be there in the advertisement, who's taken to task, not the hospital which has put their photo there. So what is the line between these two?
Yeah, I understand. So basically, this is a very common question, and there is a little bit of unfairness when it comes to all these rules apply to individual doctors. So if you're an individual doctor who is running a sole proprietorship concern, these rules are applicable. But let's say an entity like a corporate organization, let us not put any names, any corporate organization is
Dr. Senthil, you have your own hospital, that is different. You start a company or LLP or whatever. Let's say you have a company, and that company is the one who is running the hospital. And the hospital has... It's the same as with the corporate thing, right?
Correct. So for example, the moment you form a private limited company or an LLP, you become a business entity. But Dr. Srini as an individual is an individual. All these rules are applicable to individual practitioners, or Srini as a sole proprietorship. So if you form a company with 2-3 people, like if you add Rajarajan and me and all of us join together to create a business entity, you are looked at like any other business entity. So the business entity is something which is having to do profits. So they can advertise like any other, like, so they are no different from a restaurant chain. So for example, a hospital.
Is it not a added advantage for the corporate hospital when the individual
Yeah,
practitioners are
it,
denied these
sir,
rights?
so this is an unfair situation. Unfortunately, in India, there are many unfair situations. So we have to, I think the medical council or the doctors associations have to actually fight against it. So it's not only because last week I was in Kolhapur. So there was a corporate hospital which was actually advertising robotic cataract surgery. So basically they said the robots do the surgery in the hospital. So basically the advertisement, everything meant that so many patients actually came to individual practitioners and said, like, sir, that hospital robots are doing surgery, and they say it's more precise. So that is creating a lot of unfair advantage to the corporate bodies. But
Is it advertising or information that robotic surgery? You
no,
can take
that
it either way.
it is also misinforming, because they were claiming that robots do the surgery. So even a lot of our corporate eye hospitals start advertising that robotic cataract surgery, implying to the patient that robots are doing the surgery. And Dr. Rajiv Sukumaran is actually a human being doing the surgery. So the human being surgery might be less precise than a robotic surgery.
I
So
think they are talking about femtosecond, right? Femtosecond surgery.
Femtosecond cataract or a lens X and all these laser cataract surgery, but they were claiming that that's the common advertisement. It happens in Chennai also. Maybe it is there in Kerala also. Robotic.
We also need to address another thing which has come. Like till now, we are only talking about the NMC, that is National Medical Council. But everybody should understand that the government of India itself has brought out something called as the DPDP Act, that is Data Privacy Act, which was drafted in 23, but it has been revised in November 2025. It's a very draconian law. And especially as far as doctors are concerned, it is even actually they are saying that you cannot even share a patient's de-identified. That means you are just sharing only the picture of an eye of a patient. It is de-identified as far as you are concerned, because you feel that the patient is not exposed. But even that is not allowed in the current district. And they are very good because AI is coming in such a big way. De-identified patient data can be re-identified by AI. So this is now a major problem, and if you are found guilty of this, as far as NMC was concerned, you were only just going to lose your license. But here you are looking at imprisonment. So this is something which is extremely dangerous, and people have to be really careful, especially sharing surgical videos, etc. on social media. It's totally not allowed. Only now you can do it with the consent of the patient for educational purposes in conferences and other medical, medical fora only, not on social media. I think this has to be widely disseminated to our not only our viewers and all the doctors, because this is something which is going to act because somebody who has it is very, very draconian, the law. It is nothing to do with DM or NMC. It is the government of India directly doing it, and it will be very dangerous.
I think, sir, the new rule and all, it is telling in this way that you are not even supposed to take a selfie also inside any ward or inside any hospitals and all, even if though patients are there. So they can sue you. That is one thing. And Dr. Sendil, I have one question. Like you were talking about the patient can post. The patient can post. Suppose he is very happy, the patient can post. So what if he actually goes for a collab with a doctor or with a corporate firm? So is that allowed? We are not doing it. They are asking us for a collab. Suppose who is,
So
yeah.
actually, there is all these are gray zones, so we don't really know whether it's right or wrong. And as of now, everybody is posting left and right. So the idea of this, I think, let us not threaten our viewers also. Let them not get frightened that these are all. Only thing is being aware about these things and becoming a little bit more cautious. That is what I think
Sir,
we
sir,
would.
may I ask something that might actually frighten our listeners? See, if somebody actually gives a complaint to NMC stating this, what will happen?
So the NMC, I think, calls for an inquiry through the State Medical Council, and then there are lots of procedures, and then you can get a temporary suspension or a permanent. All those things, it is a process. So
So
basically,
it might,
NMC, I think, for
people have to
very
be
right,
frightened, actually.
but NMC
Dr.
right
Sanita
hand,
wants to ask
but
something.
yeah,
Dr.
please.
Sanita, go ahead.
Yes. Good evening, Dr. Senthil. My question, I just want to clarify this point. You told that a doctor who is a single practitioner, as per the medical ethics of NMC, there are restrictions to the advertisement, all those stuff. But if his organization is registered as a private limited company, is it a loophole for such things?
That's what we
So yeah,
discussed
if you
earlier.
are a
Yeah.
company, you
So,
become a business.
Okay, so all these things, testimonials, everything, because most of the hospitals are either private limited companies or LLPs. So, is it permissible or does it fall on the doctor? I mean, there is a possibility that he gets threatened based upon his individual status as a doctor under the NMC, right?
I think a little bit more lenient. That's the reason why all these corporate organizations go left and right, and then they advertise right from hoardings, buses, TV advertisements, everything. They are also a private limited entity where the doctors are the directors and shareholders. So the business entity has a different rule, and individual sole proprietorship doctor has a different rule. So if you are a private limited company with 2, 3 directors, shareholders, then you are a business entity. So you don't actually, there is a little bit, I think, easier way.
Okay.
Not that's more better than being a individual doctor. And I think as of now, action has always been taken by the medical councils against the individual doctors, not any companies. So till now, there is no company which has got a notice from these organizations.
You mean to say, sir, suppose if it is an LLP where only one individual, for example, for me, it's like it's a single doctor with, I mean, if the directors are different profession and all, but then it will be targeted towards the doctor. Suppose if the doctor is doing some Instagram videos and for testimonials or anything, because there's not sole doctor who is working over there. So this
So if your company is doing the Instagram video, like say Dr. Samira Eye Hospital Private Limited profile is doing the video, then it is easy, lenient. But if Dr. Samira as a personal person is doing that Instagram, then you get into the NMC. So
okay.
basically, it's a very simple thing. Company is seen as a business entity. A business entity can do promotion. They always say that, okay, I am running a business. I have to give profits, and there are shareholders. So if you don't allow me to do advertisement, then like any other business, it becomes unfair for me. That is the reason there is this discrepancy between individual doctors and companies.
Okay. Sir, one more question, if I may. In case of patient testimonials or over the social media, some patients, if they are giving the consent for their photographs or what their treatment history and all, and the doctor explicitly states that this is being consented by the patient. Still, is it under the purview of law? Is it right to do that, or
So
they are?
I can share you the NMC document. It says testimonials are not allowed even if
Yeah.
the patient is giving consent. They
Yeah.
explicitly said that even with consent, you should not be putting it.
Okay. And there is
Company-
also the
the
patient can
company-
withdraw the consent at any point of time. Then we have the moral legal responsibility
have
to remove
fairly-
it from our picture.
Yeah. Yeah.
So that's what
So
actually.
let us not put our people into fear. Basically, what we want to tell is,
Yeah.
okay, these are all the rules. Be aware of the rules. So be a little cautious when you are doing your Instagram and all these things. And more important, my aim of this talk is basically you can create awareness and don't be getting crazy for getting these thousands of followers. I think doctors are also becoming like any other people, like, oh, I need 50,000, 100,000 followers. We don't need those kind of followers. All we need is you can be a micro influencer. There's a concept called micro influencer, where all your 10,000 patients know you, you know them, and you want to continuously give them some awareness. Then they keep referring the old word of mouth publicity keeps happening. Don't go on. I feel very sad when I see the doctors dancing. Doctors are dancing with the patients. Doctors doing comedy. All those things, I think, erodes your brand.
Yeah, sir. That's
Very-
very right. That
very-
the old world way of doing things actually works even now. But sometimes you are forced to do. I think the doctors should have a personal profile on social media and a professional one, because now everything is tangled and it's very difficult for the patient also.
Yeah. So that is so maybe I think we have crossed my. I have one more presentation, but let me allow Rajarajan.
Yeah.
Presentation.
Yes.
Sir, you can go on with your presentation and maybe for 15-20 minutes. If there is time, then I can get back to my other presentation. You are on mute, sir. You are on mute.
Okay, Dr. Rajarajan is going to present.
So maybe we can have a small introduction about him. He is one of my good friends, very prominent. He's not a doctor, but a very good, has been always interacting with doctors. He has been CEO of many large organizations, including MGM Healthcare in Chennai, and then he's a part of Ophthalmic Xpert network also. Has a lot of knowledge in different aspects, but one of the most interesting topics he handles is on customer service. So Rajarajan, sir, over to you.
Yeah, sir. Our next esteemed speaker is Mr. Rajarajan, which is a seasoned healthcare thought leader and turnaround specialist with a wealth of global experience. He is currently the group chief operating officer at Ashram Hospitals, Eluru, where he oversees a massive 1,300 bed teaching hospital complex and its upcoming super specialty expansions. So, with a stellar record in healthcare management, digital transformation, and the strategic growth, he specializes in building business and service excellence. So today he will be sharing his invaluable sights on a crucial aspect of healthcare management, customer experience in eye hospitals. So please join me in welcoming Dr. Rajarajan, sir. Over to you, sir.
Yeah, thank you very much. Sorry, I was late slightly at the beginning. So today we are going to look at the customer experience in eye hospitals. So I'm going to break my presentation. I'll take you through what we call as something as a patient journey. So because I hope all of you are able to see my slides.
Yes, sir.
Yeah, you're able to see my slide, because
Yes.
if not, you have to go to your ophthalmologist.
Actually,
So-
I think that
Double
yeah,
projection.
Zoom window is opening on your slide.
Okay. So I'll just
close that window.
yeah.
Yes.
Fine.
Yes.
That's fine.
Yeah. So thank you for having me. So today we will I'll take you through the various steps of customer experience management. I will also introduce a concept called design thinking to all of you. I'll keep a note of the time. I'll say 8. So we're going to look at something called as a patient journey, which is a very interesting one, and the customer experience maturity level, which is there in each of the hospitals or your clinics. Then we will throw some light upon Net Promoter Score, NPS, PRAMES and PROMs. PRAMES as in patient-reported experience measures and patient-reported outcome measures. So outcome measures is more clinically, and experience measures is about all the ancillary services. Some of the KPI dashboards and some of the action plans that which you can take and implement in your setup. So today, when you look at it, patients choose experience, not just clinical results. Earlier, it was like patients go to the doctor who is very experienced, who has plenty of good results and stuff. Today, patients go to a paraphernalia of things. Some of the times, many of the corporate hospitals or larger hospitals, though they might not have a great ophthalmology surgeon, but score over your clinic or your eye hospital just because of that paraphernalia of services. So I'm just going to break that into some of the things for you to easily adopt and do it at your facility also. Then the other important thing is the online reviews. Today, a lot of patients. So I was about to say about the GEO, how we are moving to, earlier we were actually looking at search engine optimization, Google engine optimization. Now we are moving into AI engine optimization, AIEO. So in all this, there are like, for example, when you have your website, quoting a lot of your publications and articles with the backlink increases your website ranking organically. Similarly, when your hospital name is quoted in Google review or in other reviews, Practo, or even something like an ambition box or a Glassdoor by your own employees, like how for patients, for employees, we have Glassdoor and ambition box and various other sites. So they will rate your organization also. So if you have not paid a salary and you have sent a person out of your company, they might go and complain over there, which would reduce opportunity for another person to come and join. If many of the hospitals and this thing, they already have this thing, even if you have not created it, it is already there if somebody has gone and complained about it. So you can go to Glassdoor, Ambition Box to check out all those. So it's very important what the online reviews are with your patients or your own staff members. So there's also this emotional context of vision loss and fear, that which is larger for somebody like me who has had very good eyesight over a period of time, and in the last 6 months who's slightly starting to wear glasses, without glasses, not able to see whenever we have presentations in the boardroom. So that fear level is very, very high, and also the kind of impact and influence attendants have is increased actually. So why do we need to deal with customer experience now is most eye hospitals are clinically strong, but they're fragile when it comes to the experience aspects of it. So today, it's not just about experience, not just today's experience, not infrastructure. You can have the latest of equipment, you can have the best of expertise, but if you do not create that experience, that all encompassing experience for the patient, the attendant, and including the driver who comes to park the car in your parking lot. So that is now starting to be increasing. So CX is now linked to various discovery platforms. We talk of footfall, diagnostics, surgery conversion. We talk of engagements, nudges, referrals, and loyalty. I am 100% sure footfall, diagnostic, surgery conversion is something that you all are doing. But engagements, nudges, referrals, and loyalty is another new Pandora's box that which could be open, which could work well for each of you. So again, as I said, it's an emotion heavy care, fear of vision loss, especially elderly patients and anxious attendants, long multi-step journeys, high decisional dependence on the trust factor. So the journey design is very, very important, more than even the decor. So when I say experience, it's not just about the look and feel of your clinic or hospital, but much more the interactions, the touch points which we call in a patient journey management. So we'll look at it. So what we are going to look at is all this. This is a sum of all interactions that lead to patient cycle. How is it that the patient is knowing about your hospital or clinic? What is their first point of contact? Through your call center? Is it the digital front door? Many hospitals, big hospitals, we call something called as a digital front door. So you can go back to whoever is helping you on your IT or digital journey and ask them about your hospital or your clinic's digital front door. How do you set it right? How do you, when you set that right, automatically you will not lose patients. So how do you capture the lead? So how do you make these leads into footfalls coming into your hospital? What is the first search? When are they making the call or when are they visiting? Whether the whole registration and waiting paraphernalia in your center setups, the consultation experience, how long they had to wait for the consultation, how long was the consultation. A good consultation is considered something between 10 to 12 minutes. Okay, the diagnostics experience. Do you have a queue management system? Do you have a transparent system of telling the patient the doctor is in the surgery, the doctor is getting delayed, so the appointment time is getting pushed a little. So here is your free coffee coupon. Why don't you just grab a cup of coffee and just relax while we will make we will get further information on doctor's availability post surgery. The counseling, like some of the things in especially in eye hospital, counseling is given major focus for conversions or journey management. And the consent, so again we were talking about NMC, and again some of you were mentioning about NMC is applicable to the doctors and also medical college hospitals like us. But for various other hospitals, it's the Clinical Establishment Act, which kind of oversees the functionality. That's why having a company and getting into the Clinical Establishment Act, we are able to do some of the things. But still, the guidelines, I cannot do many of the things without the consent of the doctor. And we also protect the doctors. We will not put any doctor's photo on this thing unless and until they have completed their new fellowship or they have done the thing. So consent in that case is also very important. Consent with respect to patients is very important. I have seen one thing in many of the hospitals, there is always a page in the consent where you are supposed to pictorially draw and explain to the patient or the attendant. Okay. In many of the hospitals, that is left blank. Again, another important thing is the site marking, right eye, left eye. I know some of the hospitals which had color coded forms. The yellow form is for the right, the pink form is for the left eye. So they ensure that they don't do wrong site, wrong surgery and stuff. So the billing and discharge, the follow-up, the post-discharge engagement. So as I said, all these are part of the customer experience. Now, when you look at this customer journey, you have a lot. You need to understand first, who are your customers? It's just not the patients, the attendants and the caregivers, the referring doctors, the third-party payers, the online audience, and including your own doctors and employees. There is you can all Google about the 6 market theory, or otherwise I'll share some of the other pictures and slides to Dr. Sujit, and he can share it in your group, where you will understand as a business entity or as a doctor, who are your 6 markets, where you have to constantly, your vendor market, your employees market. So all these 6 markets where you need to make your presence felt and where you drain your footfalls from. So something which you need to go back and look at in your hospitals or in your setup is the journey stages. So what is it that the patient or the attendant goes through? See, one of the first and simple and important thing is have you ever sat in the customer waiting lounge in your hospital or this thing? So next time you go over there, or some of you, if you're still out there in your clinic, yet to close it, uh, go to your waiting area, sit in the customer chair, feel the cushion, feel the paint in the chair, see what they are seeing, smell what they are smelling, the five senses. All these are important in creating the experience. I've seen a lot of doctor clinics which is very cluttered. We go to a lot of conferences, we get a lot of plaques. What do we do with it? We just stack it up in our clinics or this thing. Eventually there would be a lot of dust. You could always, as ophthalmologist says, sir, our patients are not able to see the dust because they have come with that complaint only, but the attendants have not. So, so, so the so we get into an important concept called the journey. So when we look at the typical ophthalmology journey, or there is a Google, there is a referral, there's a call, walk-in, there is a registration, there's waiting, there's consultation, diagnostic, counseling, surgery, treatment, billing and discharge, and follow-up. But what happens is, have you mapped for each of this, who is the owner for each of these process in your setup? This is very important in your organization, in your clinic or in your hospital. For each of this journey touch point, how are you having somebody accountable other than you? Yes, you can take care of the surgery, you can do a little bit of counseling, but it cannot be a one-man show eventually. So you need to give, other people can take multiple roles also, but you don't be like a Dasavatar. You don't do a thing like you do the direction, you do the music direction, you do the camera works, you are the hero, you are the heroine, and everything, and the villain as well. So assign roles to make the patient journey better. So there are certain moments which matter in eye care. The first call response that the patient or the attendant gets, the waiting explanation, the doctor introduction. Uh, Many hospitals I've seen, I'm not taking singling out ophthalmologists, but generally doctors per se, there is a thing that, okay, you've already seen the name in my board outside, so you have come inside. I don't have to introduce myself. But that one, my ophthalmologist, whom I recently went in Chennai, so they introduce themselves. They will say, "Don't worry, we're here. You've come with this problem. We'll take care." That reassurance, one pat on the back, it just turns the story upside down. The trust is built over there. So the doctor introduction is not just telling your name and your credentials, but also giving the patient the reassurance that one single tap on their back, that makes a huge difference. The counseling clarity. So other than the doctor giving counseling, we always say counselors have to be present. I always request the doctors not to get into commercial counseling, only the technical aspects, the clinical aspects of counseling to be given by the doctor. The counselors would add on the clinical aspects and the commercial aspects and give the choice and option to the patient and attendant. If you look at it, the power of three is a selling concept which iPhone uses to the core. They introduce a very high end, the middle end, and the low end phones. The low end to middle end phone is very heavy, whereas the middle end to high end phone is very little. So they want you to translate from this to that and do the conversion into a better room or a better care or a better billing system or a better lens, as in ophthalmology, or better implant per se. So how do you deal with the surgery day, the anxiety handling, not only of the patient, the attendant? Do you give those clear information to them? We are going to wheel them in at this time. We're going to come back at this time. They will be on rest for 2 days. They're not supposed to. See, there are certain hospitals where I visited, ophthalmology hospital. Patients are not supposed to watch the TV for a day or two, but they do have the TV in the patient rooms. I have also seen some of the hospitals where 5 days first 2 days after the surgery, or mostly nowadays they're doing daycare. I'm talking of early days in my childhood days, probably. So these are all small things that you need to look at and stuff. First, post-op follow-up. Every time the patient goes out, do you put in your EMR or HIMS or whatever solution that you're following, or your CRM, what is the exact date that the patient has to come back? And does any of our team member give a reminder call 3 days before saying, sir, madam, your appointment is on such and such a date for the follow-up. You're supposed to come with all your files, details, and also complete these tests. So your appointment is at 12 o'clock, but these tests are pending. So you come at 8:30 itself, so you complete, the reports are ready, and you can meet the doctor. Makes a huge difference. And especially even post-op follow-up as well. Many people, these are some of the moments which really matters. And this is just the highlight of a patient journey management. Okay, we have the pre-diagnosis, diagnosis, post-diagnosis aspects. What we do map on this side is opportunities, process, thoughts, and feelings of a patient or their attendant. And so at each level, in the pre-diagnosis, pre-visit registration, what is the opportunity, what are the thoughts, what are the feelings? Based on the feelings, what translates as thoughts in the patient mind, the user mind, and based on that, what processes you have to do, and what are the opportunities that you have in translating that. If you can do this for simple things, this is available. The slides, the entire set, I have left it with sir. You can all take it, and you can do the necessary thing for your hospital for various aspects. So this is a typical patient journey management, how we see in a super specialty hospital or in a multi-specialty hospital, and understand the opportunities and ensure that our patient experience levels are at the best. Okay, so patients care about clear communication, time, respect, empathy, and reassurance, and transparency. You already have these data from various sources, the feedback forms, the Google or online reviews, the word of mouth comments, the complaint registers that you may have, and the customer experience metrics is the net promoter score. I'll tell you what is a net promoter score. It's just one question in your feedback form that you have to add. We have that coming up. The wait time perception of the patient, the counseling clarity that they have, and the complaint closure time from the time they've made a complaint, the TAT for closure. So that is very important. These are all some simple CX metrics you can go back and implement if you're not having a visibility on these. So when we talk of CX maturity levels, as in my second or third slide, so there are different levels. Definitely a clinic run by an ophthalmologist or a small eye hospital, you're all mostly in the level 1, ad hoc, individual empathy. So level 2 is where you get into a process-led and SOP-driven system. Level 3 is where you design the experience, journey ownership, which I showed, a journey diagram. Then level 4 is your prompts, frames, and NPS based on your journey, based on how much fuel you have in the car, where do you stop for fueling, where do you stop for this thing. So based on your frames, prompts, and NPS related comments and feedback that you get, how do you alter your journey? Then the strategic customer experience, where customer experience is linked to revenue and growth. So most of the hospitals, even if you are NABH compliant with the new version also, you sit somewhere between 2 to 3. So there is very low experience governance. We don't look at how patients are experiencing, how attendants are experiencing in our hospital. But there is a lot of opportunity when you all look into these presentation. I'm sure that you can definitely fast track to level 4 from here. And then, matter of fact, when you constantly implement some of the things in a matter of 3 to 6 months, you can get even to level 5, where you will see customer experience giving your return on investments. So, as I said, I will introduce you to the concept of design thinking, empathizing, defining, ideating, prototyping, and testing. What patient users want is empathizing, being with them in their shoes. You define the problem statement user-centric, you ideate new and alternate ideas user-centric, design product process, collect feedback is the prototyping, and test and refine in user settings is the final phase in test. This is a simple methodology of design thinking. There is a detailed one if you Google about design thinking, or if you put in Chat GPT, Claude, and all the stuff, you will be taken through multiple steps of design thinking. So there are four major questions in design thinking. What is, if you can answer these questions in your setup, it will be a revelation. It's like an insight journey that you all take into, like a meditation. What is will tell you the current reality at your setup. What if is what you want to get to. You want a new future. You want the patients to feel better. You want the process to be better. What wows? So from the patient point of view, or even the user centric point of view, what will wow them? So how to provide them the choice, the plethora of choices that you provide them, and how do you make them the customers the king, which Gandhiji said? How do you put them in that pedestal, and what actually works? That's the marketplace. So when you do implement it, whether it is working or not and stuff, so that is something which you need to look at. Empathizing is okay. You can shadow the patients, you can conduct interviews, you can observe behavior. There's a nice word called ethnography, ethnography. So ethnography is my special skill as a hospital administrator. So that has really helped me to grow in stature and understand the pulse of our customers or users whenever I implement some things new. So ethnography is something as part of this empathy that comes in the, and you will be able to observe behavior. You can conduct interviews, shadow patients. All these are part of the ethnography thing of empathizing. Defining the real problems and symptoms. So whether long waiting time is a problem or patient don't know the process and expectation. Sometimes it has happened that the patient came in and waited because 10 o'clock is the appointment. They've come at 9:45 and waited. At 10 o'clock, our people would call their names or this thing, their ID numbers for patient confidentiality. At that time only the patient will get up, and then we will do the registration processes. So we need to be proactive. We need to see how we have a proper queue management system, proper communication. We need to define our real problems and symptoms. So we need to get to the root cause, the panacea of all this. So we can ideate many possibilities. There's a lot of brainstorming that can happen. No idea is a bad idea. So aim for quantity, combine and improve. So don't look at the quality of the ideas. Always look at the quantity of the ideas, populate it, and then you do the brainstorming. Pick thematic things, put thematic things into perspective, combine and further improve. Prototyping is try fast and fail cheap. So when see, you don't have to wait till it is perfect. So you can experiment something, because if it is not working, you can immediately change. So it's like you can make and do the thing. It's like the pit stop in a F1 race. So you can try fast and fail cheap. So that's prototyping, counseling scripts, queue signage, flow decal for patient flow. If it's not working, you can change it. So those things which is not going to cost you, but you can experiment, you can understand the pulse of the patient, and suitably you can make it a permanent thing. Testing and learning is patient feedback, staff simulation, quick experiments. All this will give you the learning curve to a mature organization that can take you to maturity level 5 as well. So some of the things which you can go back and see at your clinic or hospital: clear signage, priority queues, seating comfort, patient guidance staff, concierge, maybe pre-registration online, SMS reminders, follow-up calls, dedicated counters for elderly, uh, estimated wait displays, educative videos in waiting area, waiting time perception reduction techniques, call ahead alerts. You don't have to wait and call them at 10 o'clock if their appointment is at 10. You can call them at 9:45 for them to complete the process so that they can get into the doctor's room at 10. So consultation, introduce yourself, use simple language. You have all done your ophthalmology course. The patient have not. Okay. So how do you do it from, when you look at the world from the Harry Potter world, we call them muggles. So how do we make it easier for the muggles, the common people, to understand what we are saying? Even though I was in a healthcare setup and stuff, for me, ophthalmology related technical terms are slightly Greek and Latin. Yes, medicine has etymology with Greek and Latin. So the diagnostic experience, again, the long queues, the multiple shifts, the poor coordination. How do you block schedule? How do you share dashboard? I've seen it happen in my own ophthalmology hospital where I go in Chennai. What they do is they call about so many patients in that first 1 hour. So one of the days when I have gone over there, they asked me, "Do you have an appointment?" I don't have. Then are you ready to wait for 2 hours? Then only you'll be taken. So for every 2 hours, they have a block for taking some walk-ins in between. So these kind of things are called as block scheduling, shared dashboards. All these you can implement. You can look at it and further experiment on this. Two-stage counseling, as I said, just don't have only doctors counseling. Two-stage counseling is very good. The written and verbal instructions, not only from the doctors, but a printed estimated form with your cost when you're taking this lens, cost when you're taking the other one, cost when you're going for the imported variety, cost when you're doing it in a general ward, cost when you're doing it in a deluxe, cost when you're doing it in a suite. So any of these, and simplify the consent forms. And consent forms are supposed to be customized to each patient. That is another thing which is coming up big time. Transparent estimation, no hidden charges, printed discharge summaries, please clear follow-up plan. I'm sure some of the patients would have come and asked, can we get the discharge summary in Malayalam? Because I sit in a place where they're asking me, can I get the discharge summaries or the treatment summaries or even the prescriptions in Telugu? So going vernacular helps capturing the market as well. So clear follow-up plan, when they have to come, what tests they have to do, in case of emergency, what number they have to call, whether have you tested those numbers, what you have printed on your letterheads and stuff around the clock, whether they're all available, or is if during the time it is available, are they picking the calls, or do you have a call forward if any of your staff who's handling that particular number is not reachable? So all these are some quick checks that you can do. Follow-up and aftercare, as I said, SMS reminders, tele follow-ups, feedback requests. Do every time patients have to come back? You know, we live in a world of telemedicine. Dr. Sendil and me, we are part of a very big organization called the Telemedicine Society of India, which has to be created for connecting us as well. So a lot of things can be done in the follow-up and aftercare aspects. Staff training is very, very important. Empathy as a skill is a very important superpower you need to teach your staff. Active listening, clear communication. How many of your staff sit down in the reception and collect the papers from the patients? How many of your staff don't even have a eye contact with your patients when they're talking to them? How many of your staff stand up and receive it with a half smile, thank for taking those things? These are all small things that could make a huge difference and stuff. You know, as I said, the net promoter score question, how likely are you to recommend a high hospital to others? 0 to 10, 0 being the lowest and 10 being the highest. 0 to 6 is considered as detractors, 7 to 8 as passive, 9 and 10 as promoters. There is a formula. I will send a separate slide to Sir so that he can share it with you all. How to calculate the net promoter score. It is detractors minus promoters by 100, and usually any score about 72 is good. I have had organizations where our scores were 90, 95. You know, I started in that organization when the score was 80. When I transited out of the organization, the score was 95. So that's a kind of experience we create for our patients. So PRAMES is all about, sample ophthalmology PRAMES, waiting time, explanation, clarity. So in your feedback forms, do you have some of the experience related questions, counseling understanding, staff empathy, billing transparency, where they can rate, and also have an open-ended where they can tell you what improvements, or they can just tell what are the other improvements that can happen. Prompts, there are a lot of things, improvement in vision, post-op comfort, ability to resume daily activities. Many of the surgical specialties have a surgical scorecard. there are many websites also which talks about it. Say, for example, frames, if you want, you can go to Kaho's website. There's a lot of frames related white papers released and materials available. Proms is something which many organizations are working. ICOM, ichom.org.uk is a good site. Like that, there are a lot of other sites which gives you surgical scorecard and various other things. Surgical safety checklist is something World Health Organization already has. Are you all following that? If you're an NABH, I think you would all be already in line with that. How do you integrate this NPS, frames, prompts, Google review? So how, as you're all, many of you are sitting at the helm of your hospital. So have a concise dashboard which combines all these things, and you will understand every day, even in your mobile while you're getting to your hospital, if you're not driving, that is, have a look at your Google reviews, yesterday's Google reviews, how many patients have said good things about you, how many people have said bad things about you, like that. And then, so when it comes to all these feedback, you take these feedback and define the problem statement, understand the root cause, solution the idea, assign a owner, create a key performance indicator, and have a review date. So if you can assign this, I think you all can really get to maturity level 4 and eventually to maturity level, customer experience maturity level 5. So how do you link CX to revenue? You will start seeing something called as an OPD retention. Your customers will come back to you. Your dropouts, see, for example, many of our patients are doing window shopping. They will come to you, they will go to another, they will go to 3, 4 people, and then eventually take a decision on going to one person. So you will start seeing, when you start focusing on customer experience over a period of time, your dropout ratio, if you are already looking at dropout ratio, you will see considerable decrease in your dropout ratio. That which means you will retain your patients, surgery conversions would improve, referrals would improve, online reputation would improve, your bank accounts of your organizations would also improve. So customer experience is not a luxury, it is a discipline, it is a leadership visibility. And as ophthalmologists, I don't have to tell about this visibility to you all. Thank you very much. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Margaret Mead is a very famous anthropologist from ethnography. We are getting into anthropology. So this is what she had to say. And thank you very much. Thanks for having me today.
You're muted, Samira.
It's a wonderful talk. Actually, we can discuss on this customer experience like for many hours. It will never end. But still, few things are like prompts and all these are totally new to ophthalmologists, people like us. So will be the stage is open for discussion. Dr. Srini and Dr. Marin.
Sir, you talked about the doctor introducing himself to the patient. I mean, I have never done that, and I don't know how many of us do that. But the rest of the things, patting, being nice to them, how important is it when the patient gets into your OPD to introduce yourself?
Sir, I'm sure many of you doctors, you don't get time for your fitness goals. We don't achieve the 10,000 steps and stuff. But one small thing, every time a patient is exiting, walk them out. Every time the next patient who's coming in, walk them in. And that small talk from your outside in your waiting area to your, this thing will make a huge difference. In fact, in NHS, this is a prescribed way of dealing with patients. I've seen this in many multiple international organizations. In India, it is a lost art. In the past, it was happening. So the doctor just walks out and this thing, and it is good. Instead of slouching on our couches, that 2 minutes of walking out and getting some air and coming back into our room with the next patient. And so there's also a thing of something called as small talks. these small talks, because you talk only technically, clinically with the patient. Okay, so you don't generally ask them. Sometimes some doctors do ask, where are you coming from? How are you feeling today? My name is so and so. I've done so many things. So don't worry, you're in safe hands. That assurance while you're walking them back,
Can I add a
creates
word
magic.
here?
Yes,
So,
madam.
so the thing is that, see, we also have to understand context. Now, what sir was just talking about is true. You have to assess your patient as well. Most of us, like Srini, would be, like there is a difference between an urban patient and a rural patient, and they have certain expectations of you. Now, if you tell a patient who comes from a rural area, an elderly lady, that I am so and so, the takeaway for them is very different from an educated person who's coming from, say, a multinational, working in a multinational. So there has to be context. There is not that you just go around in this. This is what I have found from personal experience. So I have a wide variety of patients, both from, like, we have a lot of NRIs coming in, and also we have a lot of rural patients. The way I approach them is totally different. The rural patients wants you to be there for them. The NRI or the educated patient is looking at you as a peer, asking for questions. So the two patients have to be, this is very, very important. Like, you go and approach someone and say that, an old lady coming and saying, I'm Dr. Marin Paul. It just goes,
Unheard.
exactly. So there has to be context. You cannot say that this is right for it. Yes, NHS probably is, it works, because the kind of patients that you're seeing there, their expectations of a doctor is very different from what you have in India. And probably, like, in bigger cities. So urban and rural populations, big difference. Again, very, possibly, how do you say, controversial view, but you also have to look at the economic status of the patient also. A patient who is coming from a very poor economic status is already very intimidated. And when you try all these kind of techniques on them, they feel more intimidated. They, instead of saying, Amma, I know what is your problem, and you, like you said, pat them on their back, I think that gets to them a bit, more than, being all this formality thing. But yes, there is a place for it.
And there are some practical difficulties, like I worked for a few months in UK, where what you said is very right. You go out, greet the patient. That is not at all practical in Indian scenario, because you see just 10 or 15 patients in UK a day. Here we see about 50, 60, 70, even 100 people. So you cannot keep walking. That the second.
No. So I'll tell you another trick, sir. What we do in many of the big hospitals is we put all our new patients in the morning slot appointments. We put all our follow-up patients in the afternoon slot appointments. So you don't have to do this for every patient, but
I understood.
who are your new patients. I'm not saying you have to do it for everybody.
No,
but when you
I do
it,
this
you will feel
within
the
my
difference.
room. Within my room, as they enter, I just greet them and make them sit. I do that, but not
For
going
each their
outside.
own.
Yeah. The second thing is, I've been practicing here for past 32 years. So all my patients outside, they know me. So if I go out, everybody will want to join me and walk in. So it is not practical, that's what just like what Dr. Marin said, it is not universal that you have to do. You have to customize to the situation and do. That's what I'm trying to say.
Definitely.
And in fact, when sir was telling about that patting the back, some people, in fact, does not like that also. Because one of my patient was telling me that when I go to the doctor, or they just don't tell anything. They just pats my back and they just do something. So that is not what we want. So it varies from person to person.
Don't pat alone. Do also clinical related aspects. You have to balance it all.
Correct.
See, actually, what happens, I've seen many doctors directly practicing. One thing is, many times there is no eye contact. When a patient walks in, many doctors are having this, I don't know, they are in the computer. They most of the time, or they have a sudden phone call coming. So what patient, because what we have to understand is, This going out and calling, all these things may be applicable for urban or patients, but even a patient from the village these days are expecting some kind of a customer service. So maybe at least eye contact, at least giving him that undivided attention, because he has been waiting for 1 hour, 2 hour to see us. And when he walks in, even the 2-3 minutes, if we are not giving him without typing this, because sometimes many doctors have this attitude of typing the thing on the EMR. So they don't look at the patient at all. They're always, whatever say, they are looking at the computer screen. And sometimes that timing given. So what he expects is a small smile, an eye contact, and then giving him the 2-3 minutes without attending any, because nowadays phone calls are also common. WhatsApp people want to see in between. All those things are negative, and even a rural patient, I think we should be giving him that time, even if it is 2 minutes also, it's fine. But giving him the 2 minutes, because we need to understand that he has been waiting for hours to see us. And then even when he is inside, if we are not able to give him the time, he gets upset. Rural or urban. There are certain things for every patient. Certain things we can do only for rural. Certain things we can do only for urban.
Correct.
So do we have time like for another presentation, or are we?
Yes, of course. We'll go. Continue.
Okay. So let me.
Yeah, while loading, sir, I mean, I'll just ask Dr. Rajarajan, sir. So can you just let us know that, can you just let me know like some 3 simple zero cost, that is zero care, the customer care gestures, which we can start from tomorrow for those who are listening.
Eye contact.
The simplest 3 ones so that we can start.
The simplest is, I think a lot of battle is won and lost at the reception area. So as doctors, the waiting area and the reception area is going to be very key. It need not be swanky and all the stuff. It needs to be in a nice way. As I said, you can do the 5 senses test over there. What do you look when you sit in the patient chair? What do you smell when you sit in the patient chair? All those, what do you hear when you sit in the patient chair? How do you feel the your hand on the this thing? What do you feel? Are the metal cores and stuff? So the 5 senses test at your waiting area is one important thing. Doesn't cost much. When you do that, it will give you. See, you're all great in giving super sight to all your patients, but look at it and take some of these insights and as deemed fit, implement it. So you need to also look at it from your reception staff, how they respond to the patients. It's empathy. Empathy training is not going to cost you this thing. There are dime a dozen empathy training handbooks and presentations. You can know about it, and in a small huddle, you can talk about it to your team. One of the things when I was working earlier in a small hospital in a North Indian region, so every day I will tell my staff, okay, when patients come, they come with their problems. When you come for the work, you don't come with your problems. Keep it in a bag outside the hospital and come. Here you are there to take their problems and address their problems. So how this, and you have to travel through their things. So empathy is one thing. And some of the aspects related to, the patient journey management. If you can chart out the patient journey in your facility and suitably do that, it will be great. So these are my 3 takeaways that I will tell you to go and see whether there is an opportunity to implement at your place.
Rajarajan sir, before Sendhu sir starts, this might be very simple things. How important is proper canteen or tea shop in your hospital? How important is having a TV or some other entertainment facility in the hospital? The charging points for mobiles, do these matter?
It does. In today's scenario, it does. There was even a food blogger reviewer who came to my previous hospital and put it on YouTube. Some of the hospitals where I work, we've had chef in our hospitals from ITCs and Taj and all those places. Today, in many of the hospitals that I work, we have a position called as a hospitality head. These are predominantly from the F&B industry or the hotel industry who have had a general manager level position. and stuff who have transitioned from hotel industry to hospital industry. So all these matters, sir. Like for example, when you are going as a patient or an attendant in some other hospital or some other clinic, what are the things that you would look at? Do you need a charging point? Maybe charging point does not make sense nowadays because everybody has a charger or phone batteries do last a long now, unless they're IP patients and they're going to stay in your hospital for long. Tea, coffee, snacks, quick service, restaurant, very important. Very important. The kind of, and again, the quality of the food over there, the rules say, for example, if the guy has loaded the samosa in the morning and he's going to clear it out in the evening, there is a problem that you're going to have with FSSAI. So every 4 hours it has to be thrown out. You can't keep the same thing and stuff. So how do you, so many of the hospitals nowadays, what they've gone is they've gone for baked goods, they've gone for tetra packs, healthy tetra packs, they've gone for raw and pressed fruit juices, which are kept. So for each their own. As I said, I do not know where your hospital, where your clinic are, whether it's a rural setting or an urban setting. But from that point of view, as you as a patient or the attendant, when you go to another hospital in that area, what are all the things you want to look at as an experience? If you can list the 3 or 5 things and implement that in your hospital, it will be great.
See, I think one of the biggest problem for patients or one of the biggest reason for negative feedback is one thing is waiting time. So patients are not really worried about waiting time, but patients are more worried about how much time you should wait. For example, there is a lot of uncertainty in the patient's thing. A simple queue management system. I think most of us have a software. Just but putting a small queue management system where patient knows that, okay, I need to wait for another 15 minutes to see the doctor, or the process works like this. So first I go to the optometrist, then the optometrist to the ophthalmologist. So the waiting time, if the patients are not worried about waiting, but patients are worried more about uncertainty, how much time I should wait to see the doctor. That is avoided using a simple queue management system, not expensive. Other thing, even before having these chef and all these things, is also other point of discrepancy is restrooms. The bathrooms are not very clean in the hospital. So if you are putting a special person to actually look whether that toilets are kept clean, that will definitely help. But now what Rajarajan sir says is the hospitals are taking the customer service to the next level, almost like a hotel. Like yesterday, I was in Apollo Hospital, Greens Road, where the VIP suite area, there is almost 3-4 chefs kind of a person waiting. The menu for attenders is almost like a hotel. So they have everything from fried rice to everything for the attenders. So, and somebody comes and asks you for every 10 minutes, there is somebody coming and asking you for coffee and everything. Maybe those are not applicable in a smaller setup, but at least basic necessities like are we having clean toilets, and are we giving that experience to the patient where he doesn't have to wait for a long time. A small patient journey map, like, okay, putting up a chart in the reception saying that, okay, patient when he comes in, this is the process, reception to optometrist to doctor to procedure to OT and all.
As simple as water dispensers, sir. Many people,
Yeah.
what we do is we keep a water dispenser, but on top of it, we put an ugly can. So there are
Yeah.
these can covers which is about 80-100 bucks. So you can cover those old cans, and it's all simple thing. And from your waiting area, whether the patient or the attendant is able to have access to these things, clean water, good fresh air or air conditioned purified air, those kind of things, access to the restroom. So these kind of things really matters in a clinic setup. Yeah.
So I think maybe we should go to my presentation. So is my screen visible? Can you see my screen?
Yeah.
Yes.
Yes.
So maybe in the next 10-15 minutes, whenever you want me to stop, you let me know. So we'll just continue as long as you don't get tired. So collaboration is something very difficult for doctors, basically because all of us are having similar knowledge levels and all of us do the same thing, and we don't want to collaborate with another doctor or particularly ophthalmologist. But these days, collaboration, if you are wanting to become successful, you need to collaborate with a lot of people. For example, even this webinar, what we are doing now is a lot of collaboration, because I am collaborating with Mr. Rajarajan, who is from a different line, maybe not a doctor. And this is a collaboration between me and the society. So everything in life is about collaboration. So if we understand how we collaborate with each other, I think that is something which will improve our practice to the next level. So let's see how collaboration is not only for human beings, even animals start collaborating, are good in collaboration. So let me, are you hearing the voice also? So these are two monkeys which have to pull the rope together to get the food to them. So they need to pull the rope and tandem to get the food to them. Oh, no, animals is not working. There is a support from the other animals, motivation from the other animals. Sorry, let me just go to my next slide. So collaboration has no hierarchy. Even the sun collaborates with the soil to bring something different as the flowers. So when we start collaborating with each other and collaborating with a lot of different kind of players, we can bring in a lot more flowers into the field of ophthalmology also. For example, let's say this is a small activity which we do when we are in a physical session. I ask every participant to write in a piece of paper, okay, my great idea. You just write these 3 words, my great idea, and you crumble it and keep it in your own hands. Your great idea is not going to work. But if you actually open up, discuss with each other, then the great idea will work. So meaning, if you even have some good idea about your practice, something you want to improvise on your practice, unless you share it, unless you collaborated with many others, it's not, we can practice as a small player, but if you really want to improvise, if you really want to grow as a large practitioner, I think collaboration is important. So what are my collaborations basically? Why am I qualified to talk more about collaboration? I've collaborated with a lot of diabetologists, almost 300 plus diabetologists for diabetic retinopathy screening, a lot of ophthalmologists like you for practice development, for equipment manufacturers, software development teams, and recently we also started collaborating with optometrists to launch the academy. So basically, collaboration will help us in growing. Just trying to improvise on how the collaborations work. So this is a very interesting experiment called the super chicken experiment done in an American university, where if you put all the aggressive chickens together after in one place, and average group together in another place, basically the aggressive chickens after a particular point of time, many of them die, and average chicken survive, they become more larger, they create better quality eggs because they have support of each other. So If we as ophthalmologists, everybody is competing, everybody is on an aggressive way, I think after a certain point of time, growth will not be there. But on the other hand, if we are supportive of each other, the ophthalmologist is not that advantage to support each other, I think we can create a lot more in terms of collaboration. There was also another experiment where MBA students were all put together in one place, and then kindergarten students were put together in another space. They were asked to build the tallest structure using certain items like the sticks and then needles and all those things. So the MBAs were not able to build the tallest structure anytime. The kindergarten students built the tallest structures basically because MBAs had a lot of discussions about who is in charge, who does what role, and there was so many egos and status issues. Particularly as ophthalmologists, you can compare us with the MBA students. But kindergarten students, they were always supportive. If there is a failure, they were thinking how to overcome the failure. They didn't have any egos. They didn't have any hierarchies. Who does? Everybody was doing everything. So if you want to succeed in life, I think we should be like kindergarten students and not the MBA students. Unfortunately, ophthalmologists we have these difficulties like who will be in charge, who will do what, who is bigger, who is smaller. I think collaboration doesn't work that way. And in life, we can always divide people into three categories: givers, makers, and matchers and takers. Givers are people who always want to give things to others. Takers are people who always take things from others. And matchers are people who kind of, if you do something for me, I will do something for you. So more of giving is needed. I think as we give more and more, as we collaborate more and more, I think we can also succeed in life. So more important to become givers than takers in the collaboration. So why should hospitals start collaborating? Because this is a very interesting slide. The industry of ophthalmology, though there is so much competition from the corporates, we are cribbing about corporate competition, charitable competition, competition from the government, but still only a very small segment of the ophthalmology industry is now under consolidated or and with the corporate players. But still there is a huge opportunity because India has got highest number of people with vision problems, with untreated cataracts. India has got the highest number of people. And now with the COVID and all these things, I think number of children with myopia, highest rising prevalence of refractory error. Diabetes, I'm sure all of you know that it's got so much of more people coming in with diabetes. And as you see on the left side, eye care has the highest total addressable market of all the specialties. If you take urology, if you take dialysis, if you take IVF, eye care has got the highest total addressable market. So we as ophthalmologists are in a very interesting aspect of segment of our lives where we can actually take care of this growing opportunity. But we can be a part of this opportunity only not as a single practitioner, but if we are able to collaborate with each other. And Indian eye care industry offers very significant potential. As you can see, 1 in 5 out of people have vision loss. And then ophthalmologists are also not that high compared to other countries. Indian population, a lot of 70% of them above 60 or 70 suffer from cataract. Refractory error, almost half of our population has got refractory error. So huge opportunity for ophthalmologists to grow, and we are just in the initial stages of this part of the eye care revolution happening. So if we put our minds together, I think there is a huge opportunity for all of us. And eye care is one of the most successful business models in the single specialty, as you can see in this slide. Basically, it's something very interesting. Just let me give. So the total addressable market is very high in terms of organized player, unorganized. Still, there is a huge number of people who are unorganized in eye care. And then a lot of opportunity for us to collaborate and grow. Yes. So when we want to collaborate, how do we collaborate? I think there are two things important. So there are people, we have to find people who want to accomplish. That is something important. So a senior ophthalmologist finding another junior ophthalmologist who really wants to accomplish things. Another important thing is to have people who have complementary skills, because if you see all the collaborations in other industries, for example, Apple, where Steve Jobs and Steve Wozniak collaborated, where Steve Jobs was more of a marketing person, Steve Wozniak was more of the technology person. So we need to identify people who have complementary skills. And the last point of essence and form is something very important. Before we form a partnership, there are two things we have to consider. One is the essence of the person, meaning we can only collaborate with people who are ethical, who have some value systems. And form is the way we execute the partnership. For example, in terms of documentation, who puts in how much money, what kind of exit option, all those things are the form. But what is important, many times before when we are collaborating with the person, we directly get into the form. We don't get into the essence. So we have to get into collaboration only if we understand that person has got ethics, moral values. Only if the essence is important. I think it's not only for ophthalmology, anything in life, I think we need to consider these two things. The form will come later. Form is basically what kind of partnership, money or documentation. But many times we get into the documentation part before we understand the value system of the person. So if we really have to collaborate, I think understand that we need to understand the essence part of it before we collaborate with somebody. So let me give you another video. So this is another experiment with the monkeys where they also resist about unfairness. So if you are any collaboration will work when there is fairness.
Because that's the task. And
are you able to hear the voice in the video?
Yes.
Okay.
we give her a piece of cucumber and she eats it. The other one needs to give a rock to us. And that's what she does. And she gets a grape. And she eats it. The other one sees that. She gives a rock to us now, gets again cucumber. He tests the rock now against the wall. She needs to give it to us. And she gets cucumber again.
So did you understand the concept behind this video?
Well, that's the
1 minute. So basically, any kind of collaboration also needs to have some amount of fairness. So when there are two people who are partnering, two people who are collaborating, I think fairness has to be there. Otherwise, the collaboration may not work. And as ophthalmologist, there is always a myth that, okay, I should be the smartest person in my hospital. I can do everything on my own. I don't have to have smarter people with me. I think that we need to overcome the myth of this individual excellence. Though we can be excellent, we need to focus on excellence when we deliver the service to the patient. But we don't have to think that, oh, I should be the smartest person in my hospital. So that is the biggest challenge in when we want to collaborate with another person. For example, let's say Wipro Asim Premji, he was not the software person. He was not the most excellent, skillful person or the smartest person of the company. But he had the opportunity, he had the skill set to bring in people who were more excellent, more smarter than him. I think if we need to collaborate, we should also overcome this aspect that, oh, I should be the most smartest person in my organization. That is something we need to overcome. All the like say the Silk Road, which was created for the transport of in the olden days, or the library, the great library of Alexandria, or the Harappan civilization, everything was created because of collaboration. But collaboration happened with multiple people. So other thing is, we always think that, okay, as a doctor, I should only be collaborating with another doctor. But that's not the scenario. As a doctor, we can collaborate not only with ophthalmologists, we can even collaborate with other specialists, for example, diabetologists, or We can even collaborate with, for example, let's say you are running a LASIK center. So you can even collaborate with salons or beauty parlors. So there is a lot of opportunity to collaborate with different kind of people. The first thing which we tell doctors is, don't think that collaboration has to happen only among doctors. Collaboration can happen with multiple different organizations. For example, we used to give this example of this hospital in Barcelona, which was a pediatric hospital. So pediatric hospital wanted to promote its services. They were thinking, okay, how do I promote? What kind of marketing we have to do? So generally the suggestions came that, okay, you can collaborate with other doctors, go and collaborate with other pediatricians, or collaborate with the schools to run the school camps. All those things, but there was an unusual proposal where they said, why don't we collaborate with a bag maker? Because in Spain also children were carrying these huge bags on the back to school. Most of the parents were worried that the children might get spine problems. So the hospital started collaborating with one of the largest bag makers in Spain. They said like, okay, design a bag which will reduce the impact on the spine of the children. So you give some support and we will promote that bag together. So basically, collaboration can happen with anybody. We don't have to think that I need to collaborate with another doctor only. And if you see organizations like LV Prasad or Shankara Nethralaya, they have collaborated with multiple number of people. For example, they have collaborations with Microsoft for AI, Google for AI. They have collaborations with intraocular lens manufacturers. They have collaborations with the governments, collaboration with international organizations. So many collaborations lead to that organization becoming bigger. So as an individual ophthalmologist also, we can still think about collaborating with multiple kind of people. For example, nearby physicians, diabetologists, optical shops, maybe even collaborating with associations, educational institutions. So there is still a lot of opportunity for us to collaborate. But if you want to grow your practice as an individual also, you should form these multiple collaborations. And if you want to become a larger organization also, these are important. And I think importance of leverage. Leverage is one of the biggest part of collaboration, using other people's time, other people's money, other people's knowledge, other people's skills, other people's experience, initiative. We always are thinking that, oh, should I use the knowledge of another person, or should I employ other person to collaborate? So basically, the largest of the largest organizations have grown because they understood the value of this other people. So other people's time, money, knowledge, skills, experience, initiatives, innovation. I think everything we should leverage. Then I think even just like how you use this bar to lift this heavy load, you can create a larger practice. So how did this? Yesterday I went to Apollo Hospitals, which has started as a 150-bed single location hospital, has grown to I think almost 20,000 beds now, which is because of so many collaborations with the financial institutions, with different doctors, different industries, which led to this growth of this organization. So whether we want to remain as a single solo independent practitioner, or do we want to grow to a larger organization, or even as a single practitioner, how do I create these multiple collaborations to grow? That is the idea I wanted to drive through this presentation. So this is the story of that pediatric hospital, which I told you already. So this hospital collaborated with the bag maker to create those bags which reduce the impact on the spine. So let's see the example of a company like Reliance, how many collaborations they have, right from Google to Siemens to Microsoft. So these are the collaborations of Reliance. So this is the collaboration of LV Prasad Hospital. So Alcon, CBM, Cornea Contact Lens Research Unit, NIH, Santon. So there are these multiple collaborations, including academic partners, to grow that organization. So individual hospitals, you can collaborate with other ophthalmologists, you can collaborate with physicians, diabetologists, neurologists, NGOs, optical shops, educational institution. Basically, you can collaborate with anybody as your imagination goes. So eye hospitals, group practice, maybe even medical associations, how do we work with them? industry, optical outlets, telemedicine, or other telemedicine organizations. So there are these collaborations which are possible. So let's.
You are a cover-up artist and you are a liar. I'm not a snitch. Excuse me? This is such a crock of shit. You're building a rat ship here. A vessel for seagoing snitches. And if you think you're preparing these minnows for manhood, you better think again. Because I say you are killing the very spirit this institution proclaims it instills. Sir, you're out of order. I show you out of order. You don't know what out of order is, Mr. Trask. I'd show you, but I'm too old. I'm too tired. I'm too fucking blind. If I were the man I was 5 years ago, I'd take a flamethrower to this place. He won't sell anybody out to buy his future. And that, my friends, is called.
I think this is from a very interesting movie. I forgot the name of the movie. So basically, the idea is don't sell the soul to buy a future. Whatever collaboration, whatever we do, I think more important is also following that ethics and value systems. So something like I wanted to end the presentation with this kind of this thing that whatever we do, we should not be selling our soul to buy the future. I think that's something very important. And so what maybe I would like to end up by proposing a simple idea for our ophthalmologists. Now there is this huge corporate brands which are coming in, and individual ophthalmologists are finding it more and more difficult to survive in the competitive scenario where you are going to compete with these larger brands. So there is always an opportunity where without selling our practices, we can all be a part of a collaborative network. For example, how the Star Alliance has been formed in airlines. We all can together, like say Dr. Sujit Nayanar's Eye Hospital, a part of another network. Or let's for the namesake call it as Opthal network. We also associate. Once we have that larger presence under a common branding, right, and a lot of benefits can come, right, from becoming marketing, where we can have a common website to get patients, digital marketing, having a back office, because very difficult for people to have a back office as a small eye hospital, but having a common back office for say 40-50 hospitals together, where we have somebody for insurance, we have somebody for HR management, we can have somebody for even procurement, all those things. And main thing, I think, when we procure together, we as single individual hospitals still can also have the competitiveness with the corporate hospitals. So we can actually have why this is more and more needed, because nowadays I see a lot of ophthalmologists who call me and say, like even from Kerala, these doctors who are 60, 70, many of the children of ophthalmologists are not becoming ophthalmologists these days. So when your children are not becoming ophthalmologists and you're not also able to sell your practice to a corporate entity, so and if you are a part of a larger network, say a junior ophthalmologist can from the network can take over your practice and run your practice, because getting a doctor to join you is also becoming more and more difficult. So, but when you are a part of a larger network, a kind of a group of organization, this can give you a very good option for exit, where a junior doctor can actually buy your practice or be a part of your practice, run your practice. Because what is happening is we see doctors exiting to the corporate organizations, but there are also a lot of practices which are dying out along with the doctor. Say somebody who's 60, 70, the doctor creates a larger organization all along his life. He builds that practice, but suddenly if the doctor is incapacitated or not able to practice, whatever he has created for a lifetime goes to zero. What the doctor can get is just the depreciated cost of the equipments. But I think now the time has come where we all have to join together, think about how do we collaborate together to come under a common brand, running our practices still independently, but also leveraging the potential of being a part of a group. The biggest advantages, other thing is, see, when we all are a part of a bigger group, the valuation which we get in terms of whenever there is an exit, we want to sell to a corporate, is far more than what we can get individually. It's not that everybody should exit. So there are multiple advantages of becoming a group and being together a part of a larger network. There are so many challenges. There are individual egos, so many things. Many people have tried this before, but I think now is the time to become a part of a collaborative network. So what can the network do? Digital marketing, social media, common website, brand ambassador, podcast with influencers, call center can be had. Maybe if there is a possibility, there is budget, we can even have radio ads, partnership with corporates, referral models, tie up with aggregators and healthcare financing, and insurance operations where we can have a common insurance manager, CRM software. Rajarajan sir spoke about CRM, shared equipment, maybe a specialized referral network, wholesale price access to consumables, HR manager, AI software, so many things we can do together if we become a part of a network. So everybody has a good value proposition, right from patients. There are investors get a value out of this. The doctors have a lot of value, and the network also gets benefited. So it creates a win-win situation for all of us if we become a part of a larger network. So it's just an idea. I'm still working on it, and maybe let us have the discussion about this initial idea, which I just floated to all of you. And hopefully we will get it started when the time, maybe within the next 2-3 months, and I'll keep you informed. And this also, I wanted to float this idea on the forum before the end of the session. And thank you all for patient listening, and thanks for the opportunity. And if we have time, can take some questions. I think, madam, you are muted. You have to unmute.
Yeah, thank you, Dr. Sandil. Very nice talk on this collaboration. I'll ask you one question. Like, if for a solo practitioner, they want to have a transition into collaborative practice, so what is the very first critical step which they need to take?
See, first thing is, I think many of our colleagues don't think about mortality. They think that, oh, I can be immortal. So they till the age of 60, 65, because nowadays 90% of the children of ophthalmologists are not becoming ophthalmologists. So we need to think about this at an earlier stage, say 45, 50. You should think, okay, what happens to my practice after me? That's the first awareness of that. And the second thing is maybe trying to bring in a junior inside if the practice can sustain another person. And whatever I say, sometimes it's very difficult. Even whenever people want to start practices, I always tell that, okay, try to get as a group, maybe at least 2 people joining together, because you can have so many advantages if you are a group. I know there are so much challenges. 2 doctors uniting together is not that easy, but I think that's the way to go for the future. Somehow we have to crack that. Somehow we have to put the egos behind, and 2-3 people joining together and starting makes a lot more sense. And thinking about, okay, I'm also mortal. I need to think about what happens to my practice after me. So should I bring another collaborator, another doctor to with me? Or that's when, because so many doctors keep asking me, there are people who are 60, 70 years old. They say, sir, I've been practicing individually. I have this many patients and everything coming, but my children are not doctors. What happens to my practice after me? Because every practice is not acquired by a corporate. They are looking at particular size of practice. They're looking at younger doctors. Somebody who is 65, 70 is not very attractive for the corporate to buy, because he wants the doctor to work for them for another 5 years, 7 years, which may not happen. So somebody 50 years, 55 years is more preferred by a corporate organization. So thinking about that, that's when we thought, okay, why don't we form a larger conglomerate where we all associate under a common brand and have all these things done in a common way. It's a thought process. I know it's not easy to do, but I will try to do it. Yeah.
I totally agree with Dr. Senthil on this, that a group practice is definitely the way to go, especially in Kerala, where we have this high percentage of doctors as compared ophthalmologists as compared to the rest of the country. Here we have, like, doctor was showing us those figures of ophthalmology penetration into the population. But I think in Kerala, it is positive. The numbers are much more than what is required. And the way forward is only group practice. There's no other way. Otherwise, everybody will be working for corporates or, these chain hospitals.
Yeah, another thing I see in Kerala particularly is many of the eye hospitals in Kerala are owned by business entities, not by that is very different from other parts of India, because the owners of eye hospitals mostly are ophthalmologists. But in Kerala, I think many people who are businessmen start eye hospitals, which is also, apart from the corporate, something very different in Kerala. So most of the time, if we don't do it, many of our ophthalmologists will end up working in those business entities.
Now we have a new thing which has come, like all those medical representatives, it is their group practice. They have started taking the small clinics into picture and all, and that has become a change right now. You can see the MRs have taken up, like almost like 6 to 7 people and all, they are doing it as a group practice. So these are the business people, and they are actually running the show with multiple clinics in different parts of Kerala. That is the new thing which has come right now.
Senthil sir, the reason why the business people are starting eye hospitals in Kerala, see, one reason what Dr. Miriam Paul said, like, there are a lot of youngsters coming out. Many are fellowship trained, and so they have their workforce there, and they have the way to tap funds. Okay, so people, as you said, Aftal, they've seen that it's an industry that will give profit. So there are people ready to invest. So that is something like, it's a deadly combination. You have the money, you have the workforce. So you have talked about people who are in the retirement age group. For the youngsters, yes, group practice is one way to go about it, but it's not that easy. If a young doctor wants to start his practice, because I'm sure there are a lot of youngsters listening to your talk in this. So what should be the precondition? Like, you just start your shop in one place, hoping that patients will come in. It's not going to happen. Because I've spoken to people who have become successful, but they said for 1.5 years they just had 1, 2, 3 patients in a day. So people don't have patience for that, especially the youngsters now. So what would be your advice? I personally feel that you work for some hospital. Whichever hospital, how much ever that hospital tries to prevent you from having your own loyal group of patients, you will definitely get a loyal group of patients, and after that only you start in that area. See, I feel that is one way to go about it. Is there anything else that you would advise these youngsters to do? And by the way, that was Al Pacino in Scent of a Woman.
Yeah, Scent of a Woman. Correct. So he was a blind man.
Yeah. Excellent.
And he will go to support that boy.
Yeah.
Being expelled from the school.
Yeah.
So
your advice.
So basically, a lot of youngsters come to me these days, and then they ask me, sir, I want to start a hospital, or I want to start a clinic. Can I start this small clinic, OPD clinic, and then grow it up? So now, the first advice I give them is there is good potential in the smaller towns, not the bigger towns are saturated. Going back for the tier 2, people have good paying, particularly in Kerala also, I think even in tier 2, tier 3 town, there is a good paying capacity. People are expecting good services there also. So go for a smaller town and don't start. I don't think people are now going to come for a practice which is just a OPD clinic in the second floor of a building, because those days have gone. People want the standard of an eye hospital is now set up by the corporate hospitals. People, just like a restaurant, you want certain facilities there. eye hospital also people want certain minimum facilities, like it's in a 2,000, 3,000 square feet with the OT inside, some uniform staff, some reception, ambience, and all those things are there. So if at all you want to start off in a decent way. You cannot start a small OPD like the olden days where people say I started with a small slit lamp or a trial set. That's not going to happen these days. So second thing is, I don't advise youngsters to start unless they are already having a database of patients. For example, let's say they are already worked in a government or a charitable or a corporate. And I'm not telling you steal away their patients and come, like you pull their database and come, but you create your own brand image, you create your own experience. So the moment the day you start also, you should be having an opportunity to have 10, 15 patients coming to you. Otherwise, to get those initial 10, 20 patients only is going to take so much of time. And I don't know if the youngster can sustain that break-even period. So get your own database, create your own profile, create your own following, then you start your practice. Otherwise, it's good. So the most common people who are starting practices these days are somebody who's already worked in, for example, from in West Bengal, people who are working in larger organizations at the age of say 40, 42, 43 or 45, where they have made a decent financial money also for them, where they can actually afford to start a decent size practice and already have a database of patients. They are the most successful practitioners, not somebody who starts without any backup. That's not going to work. So start in a small tier 2, tier 3 town, start a decent hospital, probably with the OT inside, and if possible, having your own database of patients before you actually start. These are something important for the youngsters.
So whatever you have said about this collaborative practice, I think the doctors from RPC, the RPC alumni is already doing it. Probably, Dr. Raju from Karnataka, Bangalore. Srini sir may be knowing. I think many RPC.
Raju Sampanti.
Raju Sampanti.
Raju Sampanti.
So I think he and few others have taken the initiative, and those who have started their own individual clinics from the RPC alumni, they are now under one umbrella. And there's some name also, I forgot the name. Srini sir can probably join them soon. So it's already happening there. I just wanted to share that. Yeah.
The one thing about that, when Dr. Sendil was talking
thing.
about that regarding that collaborating with other than the doctors, the main issue is that you should really have to draw an ethical line when collaborating with non-doctors and all. It becomes very difficult also because their vested interest will be little bit different compared to the doctor. So that you should be very careful whenever you are collaborating with other
Otherwise,
doctors.
it will become another corporate setup. A brand is there, then marketing, everything becomes a corporate hospital. So you'll have to be very careful when you're collaborating between doctors. You should not get into a financial into it and make it another brand of corporate setup.
Yeah, so what the idea I was trying to put through is, as doctors, we always want to interact with other doctors, basically interacting with a lot of different specialties, different people, like even we learn a lot from them. We get more, let's say you are in a group of industrialists or if you are in a business entity kind of a group, so you get more reference and all those things from there. Let's not collaborate only with doctors, but collaborate with different kind of people, like see government, or if you are I benefited a lot by being a member of the CA, Confederation of Indian Industry. There is a Chennai thing, and then there is Madras Management Association. There is an organization called TAI, the Indus Entrepreneurs. These are all groups of non-doctors, but they give a lot of knowledge to us, and they also give a lot of referrals to us. So being a part of all those different groups, that kind of a collaboration helps a lot.
Yes, I totally agree. Even I am part of Thrissur Management Association, very actively participating in that. And so you have a different perspective on everything, because normally we are only associating with doctors, and we also see how the business side of things also works. So I totally agree with Dr.
Yeah, before we complete, I think I am also writing a book on psychology of medical practice. Like, what are all the different psychological things we need to understand? So once it releases, I need all of your support for my book. I'll from the Kerala Society, we need some support.
Yeah, follow up to psychology of money.
Yeah, it's like psychology of money. It's called psychology of medical practice. Similar concept, but what are all the different psychological aspects we need to understand about in medical practice?
Dr. Merin, you said, people, I've heard Dr. Mahibal Sachdeva also talk about getting ideas from people other than ophthalmology. Can you give just one example of something that has happened from which you benefited?
Yes. So the simple thing, like, financial management. So basically, like, when you as a doctor, as an individual person running a clinic, you have very little idea about financial management. So when we have also a subgroup within the Trishul Management Association called as the Women in Business, this thing. So there we have dedicated financial pathways as to how to on how to like manage your own finances, also as to how to scale up your business. So these kind of insights, especially for like I joined after I was only in the last 5 years. But if I was thinking that if I had joined this organization maybe in my early 40s, this would have changed the trajectory of my career. So yeah, definitely, I think these kind of associations help a lot. It also gives you, like I said, a different perspective. You see, when you are seeing other doctors only in your associations, your perspective is that of a doctor. But how does the community see you as a doctor is something which you also learn when you and interact with these kind of, they are your peers in terms of both educational as well as social class is concerned, but you are not generally kind of interacting with them on a personal basis other than as they are as patients. So, but when you see them in these informal settings, you understand a lot more as to how, and newer technology also, that like, that also, because if there are more people who are like dealing, who are engineers. So we have people here who are running robotic firms, etc. So your entire perspective on how things can go changes. This is what I wanted to share.
See, actually, this is called as a multidisciplinary approach because you get a lot of knowledge from different fields, which helps us in even growing our practice. For example, why this Mona Lisa was a very famous painting, not the other paintings became as good as Mona Lisa, because Leonardo da Vinci was a painter, a sculptor, an architect. He was even a military war specialist. He was even doing anatomy. So he used to dissect the bodies and then look at the veins. So all those things put a perspective on the painting. So that's why that Mona Lisa became very popular. So by attending these three management associations and all these things, interacting with people who have got a different mindset, I think helped a lot for me in my initial stages, because it opened up a lot more possibilities. So we are not telling don't attend Kerala Association meetings, attend Kerala and also attend these. So basically don't attend only the ophthalmology meetings. These kind of meetings also, because it's a different perspective, it gives a lot of relaxation also, because you hear so many different things. I even go to literary societies, a lot of these, reading books also, a lot of different genre, like from literacy to physics. All these things helps a lot, whatever, rather than only the regular ophthalmology books. So something I think that should be the takeaway for all the participants. We try to have this multidisciplinary approach, which will help, and I'm sure you can grow a lot more with that.
Yeah. You can be part of Rotary Club, Lions Club.
Yeah.
All those things, you come across a lot of different profession people. And
Yeah.
as you said, as Dr. Marin said, you'll know where you stand in front of them. As a doctor, they will rate you in a different way when you approach outside.
Yeah.
Anyway, it was a fantastic discussion we had. Let's have the concluding remarks from Sujit.
As you said, sir, it was a fantastic discussion. We have crossed time by almost 1 hour, but I think nobody is tired yet. So it was a fantastic discussion. Thank you, Dr. Senthil. Thank you, Mr. Rajarajan, for joining us. And it was a wonderful talk. All three talks were wonderful. Thank you, Srini sir and Marin madam, for wonderful discussion, and Samira for moderating it. So I think we can conclude the session. Thank you, Rajiv sir, and thank you all for joining.
Thank you very much.
Thank you, sir. Thank you, sir.
All right.